The Reverse study was a randomized phase 2 study in patients with refractory disease who had progressed on standard cytotoxic therapy but were naive to anti-EGFR therapy. They were all KRAS exon 2 wild-type patients, and they were randomized 1-to-1 to either regorafenib followed by cetuximab with or without irinotecan, or cetuximab with or without irinotecan followed by regorafenib. So the question here was sequencing. And this is something that we know very little about. And the thinking was, well, does one help over the other with regard to overall survival, which was the primary endpoint, and then the secondary endpoints were PFS1 with the first line of treatment, as well as PFS2, the second line of treatment, and then importantly also quality of life assessment and safety and tolerability. And the data were interesting. The patients that received regorafenib first, followed by cetuximab with or without irinotecan, had a statistically significant improvement in overall survival of roughly 17 to 11 versus 11 months. But interestingly, the secondary endpoint of the first PFS was equivalent. But when they crossed over, so the second PFS, there was a significant improvement in the patients that received regorafenib first. So that was a really interesting finding, and it was probably that second PFS that actually contributed to the improvement in overall survival.
The Reverse study informs us about potentially improving our understanding of how we sequence these agents. In fact, primarily focused on regorafenib. And we've known from comparing Concur to Correct, so the Asian study versus the American study. The Asian study had less pre-exposure. The US-based study, of course, patients had to go through EGFR, VEGF, et cetera, all the chemotherapies. What we've known when we looked at those two studies historically, that if you expose patients earlier to regorafenib, they tend to do better. They tend to have longer PFS and longer OS. So the Reverse study confirms that in a randomized fashion, albeit it's still a phase 2 randomized study, and also with the understanding that this was an Asian, actually it was a Japanese patient population. But what was intriguing about this study, and it was primarily powered for overall survival, is that if we start with regorafenib and follow by cetuximab versus the Reverse, cetuximab followed by regorafenib, the survival is quite prolonged, which tells us essentially the importance of considering regorafenib earlier rather than later. When I think about sequencing, which I've been doing for quite a while in my clinic, it's not going to change much my standard. However, I can tell you that for patients with right-sided tumors today, where I try to avoid using EGFR inhibitors, regorafenib will be given before I even consider cetuximab. So that applies perfectly to that patient population. On the left-sided, I'm not sure yet. I'm not sure if I would place regorafenib before cetuximab, but certainly very quickly after cetuximab.